مرحبا، يعطيكم العافية. كيف الحال؟ راح نقدم لكم اليوم المحاضرة الثانية Problem Based Learning. أول محاضرة حكينا فيها قدمت لكم شوية حالات وحكيت لكم المحاضرة هذه we will discuss them further and I will show you or will tell you what is the disease or condition in each case. I remember that I have shown you the presentation. I told you it's real cases, it's a real world scenario, and I showed you how patients present, and I also included some pictures about every case. So today we will remind ourselves about the cases, and then I will tell you what is the disease in everyone. So case number 1 was about a 12-year-old male patient requiring blood transfusion on a regular basis, and we agreed that this is called transfusion dependence since the age of 10 months and indicating a severe form of anemia, being unable to survive without regular blood transfusion. And he's receiving 1 unit every 3 to 4 weeks on a regular basis. Also, the presence of family history, we said that this indicates a familiar or an inherited form of anemia. The blood film, we said it shows aneuploidy with significant hypochromia and microcytosis. These are the features of the blood film that we are looking at. And the facial features are those of bone marrow expansion. So the bone marrow is trying to expand, trying to produce more and more red cells. The erythropoiesis is trying to compensate by increasing quantity, though quality is affected somehow. And this is because he has a genetic defect in the globin, in one of the globin genes. A disorder called thalassemia. It's a group of disorders characterized by reduced synthesis of a globin due to a genetic defect, a genetic mutation that is, or aberration that is inherited from the parents, the father, the mother, or both. The disease is generally transmitted as autosomal recessive disease, so you end up with two status, the carrier status or the affected status. As you know, hemoglobin is a tetramer of a protein that is connected to a heme molecule. And this protein tetramer is composed of 4 globin chains, and you have different forms of hemoglobin. The adult hemoglobin, the one that we rely on in our adult life, 6 months and beyond, we rely on the adult hemoglobin A1 that is composed of 2 alpha chain and 2 beta chain. So any genetic aberration in the gene encoding the beta chain or the alpha chain would result in a reduced production in one of these chains. And this reduced production would cause the characteristic hemoglobin inclusion that is caused by imbalance. So you have imbalance between the two, the affected versus the non-affected chain. This imbalance would lead to inclusion, and this leads to premature destruction of red blood cell. So this is a disease of hemoglobin production, one of the hemoglobinopathies. It's a hemoglobinopathy inherited, as we said, and it leads to premature destruction of red blood cell. So this is case number 1, thalassemia. Case number 2 is about a 9-year-old girl who presents with bleeding gums and bruises. So we agreed this is easy bruisability or recurrent bleeding gums, in addition to nasal bleeds also, and she has also again family history of similar conditions. So we agreed that she's likely to have an inherited bleeding disorder. We said also it looks severe or it looks significant because her primary doctor referred her to a hematologist evaluation. So by this we know that it's really not something just a transient or a mild bleeding symptom. It's a disease of bleeding, and we showed picture for bruising. We agreed what's on the term, what's easy bruisability. I told you where are the sites that you need to look at in order to assess the significance of bruising. It would be more significant if it would be on the trunk, areas not hit easily. We defined easy bruisability as having 5 or more bruises at the size of 1 centimeter or more each, one of them, the presence of 5 bruises at the same time. And we said that this is a bleeding test, bleeding time test, the test they are running in the picture on the right lower corner. So this is a bleeding time test, a test that is usually or routinely done to assess for this disease, von Willebrand disease, or other conditions that may be associated with the platelet dysfunction. So bleeding time is a very reliable test, or a very good test to assess the function of platelets. Von Willebrand disease is a common inherited genetically and clinically heterogeneous bleeding disorder. It's the most common inherited bleeding disorder. It is characterized by a defective von Willebrand factor, either because it's deficient or because it's dysfunctional. So von Willebrand factor is a large protein that is released from granules in the platelets or in the endothelial cells. It has 2 major roles in hemostasis. It mediates platelet adhesion to the site of injury to form the primary platelet plug, and also it stabilizes the factor 8 in the blood, preventing it from being lost in urine. So von Willebrand factor is essential in hemostasis, in particular primary hemostasis, and the either deficiency or dysfunctional von Willebrand factor would lead to this disease, in which there is a normal platelet count. When you test the platelet count, they are normal, and but the patient still bleeds. They have this characteristic form of mucocutaneous bleeding phenotype. The disease has 3 types, type 1, 2, or 3. They differ in the etiology. Is it quantitative or dysfunctional or qualitative? And they differ in the pattern of inheritance. So type 1 is a quantitative disorder or deficiency that is inherited mainly as autosomal dominant, where type 2 is a qualitative disorder. The amount of the von Willebrand factor is normal, but it is dysfunctional due to different reasons, and it's also inherited differently based on the type, the subtype. Type 3, the last type, is very rare, and it's autosomal because it's autosomal recessive, and is associated with a very severe deficiency of the factor. So it's again a quantitative deficiency like in factor 1, but it differs with the pattern of inheritance than type 1. Patients with von Willebrand disease, they usually bleed from the sites we've mentioned, from the skin, from the nose. The ladies, they usually complain of excessive menstrual blood loss leading to anemia or iron deficiency anemia secondary to this excessive menstrual blood loss. The disease is screened for by bleeding test, a bleeding time test, the test that we have shown in the picture. So bleeding time is the test to go for if you want to check for possible von Willebrand disease. Case number 3, we presented a 68-year-old male who is presenting with back pain, and it's of recent onset. The pain is located in the lower part, and it's worsening over the last few weeks. We also said that his blood His blood test showed anemia with high erythrocytic sedimentation rate, and in the first lecture I have told you about this ESR and how it's done and why it gets abnormal sometimes. I have also told you that the lower pictures, the lower two pictures are for protein electrophoresis, and I have told you the one on the left lower side is a normal electrophoresis, whilst the one on the right lower side is abnormal, showing an abnormal peak of protein at the gamma region, indicating there is an abnormal protein. And this is the screening test that we do for patients who present with such a scenario. An elderly patient with back pain, or sometimes anemia, or sometimes renal failure, and then we find them to have a high erythrocytic or erythrocyte sedimentation rate, because it indicates the presence of abnormal protein. These proteins can be monoclonal, as in this example, indicating a positive screening test for the disease we call multiple myeloma. So multiple myeloma is a malignant disorder of the bone marrow that is characterized by abnormal malignant monoclonal proliferation of plasma cells. Plasma cells are one of the end products of B cell maturation and proliferation, as you know, that are normally present. They are normally present, but only in subtle or small amount. So they don't usually exceed 3, 4, 5% of the total nucleated cells in the bone marrow. However, the excess of these cells in a malignant form, the excess can be sometimes due to reactive reasons, and these are non-malignant excess of cells. But multiple myeloma is characterized by excess plasma cells of malignant form, of monoclonal form. This excess leads to the disease we call as multiple myeloma. The excess of cells of these plasma cells leads to accumulation or increased production of protein, because normally these cells would produce protein, the immunoglobulins. However, when there is a malignant clonal proliferation of cells, this will lead to also a monoclonal or excess protein that has monoclonal properties that is very similar when it comes to its physical features. So it has the same identical features that would be seen as a peak sharp in the protein electrophoresis. As I told you last time in the last lecture, the proteins, they travel based on the net charge of this protein. The net charge is determined by the amino acids constituting this protein. So every protein, it has a net charge, and when the protein is monoclonal in excess amount, you will see it as a sharp peak, and we call it a positive screening test for multiple myeloma. So this man has this excess of plasma cells. How we confirm the disease? By demonstrating that the bone marrow has this excess of plasma cells. I mean, we have to do bone marrow. If you do bone marrow on these patients, you will find this excess of plasma cells. Also, you can study the protein in different ways. You can study the immunoglobulins, the free light chain component, because it has a heavier light chain. You can study this, and then you should assess your patients for the other signs or symptoms of the disease, such as anemia, high calcium, impaired renal function, and also bone disease. They tend to present with lytic bone lesions leading to fracture, or that's why he's having the back pain. Okay, so these are 3 cases so far. Now we will move to case 4 in this presentation. Case number 4, we talked about a 24-year-old male who presents with a new onset yellowish discoloration of the sclera with exertional fatigue and shortness of breath. We said he has very dark urine, and the patient was normal before the attack, so the disease comes and goes in attacks. and there was a trigger, that is ingestion of favabine 1 day before the onset of symptoms. We showed that he had pallor, he was jaundiced, and by that we mean he had yellowish discoloration of the sclera and the skin. He also had these abnormal cells in the peripheral blood or peripheral smear. These red blood cells appear to have a blister, or as if they have one or more bites being bitten, like bites taken out from the cell periphery. These are called bite cells or blister cells sometimes, and these are red blood cells with inclusion. So there is a inclusion termed Hens body. So these Hens bodies are usually the other name of these cells, because of this inclusion that is caused by denatured hemoglobin. So this abnormal hemoglobin can be recognized only by supravital stain, like methylene blue, but on the routine stain used in regular assessment of blood film, you will see cells like these bite cells. These cells are usually present during acute hemolytic attacks caused by any trigger in this disease. So they normally are removed after the incident by the spleen. And this patient, he has, as you would expect, he has G6PD, glucose 6 pyruvate deficiency, glucose 6 phosphate dehydrogenase deficiency, and it is the most common inherited red blood cell disorder of humans. The incidence is higher in certain ethnic groups, such as people of African ancestry or Mediterranean people, such as our region, or East Asian ancestry, East South Asian population. The disease is characterized by episodic acute hemolytic attacks following exposure to certain triggers, and these triggers can be things like infection, diabetic ketoacidosis, or exposure of certain medications, or even food supplements such as favabine, as we saw in the example. The disease is inherited as X-linked, and the gene encoding the G6PD is located on the X chromosome, and there are more than 150 variants or different types of mutation or deletions or aberration character identified in this gene leading to disease. The disease renders the red blood cells susceptible to hemolysis secondary to oxidative stress, so they cannot handle the oxidative stress as normal cells would do because of the deficiency. So then we move on to case number 5. Case number 5 is about, we presented a 20-year-old female college student, and we said that she has acute pain in the back, shoulder, and extremities. We said it's not the first time she has such an episode, and previously she had to be admitted with respiratory symptoms and was treated with blood exchange, red blood cell exchange, and I explained in the first lecture what blood exchange is, and comparing it to the routine or regular blood transfusion, and also plasma exchange. And we said that she has pallor, she was also jaundiced, she was underweight, she had some skeletal abnormalities such as infarction of the bone, medullary, and epiphyseal areas, dactylitis. She also had leg ulcers, and these abnormal cells on the blood film that we agreed to call sickled cell or crescent-shaped cells or boat-shaped cells. And we agree that these cells are characteristic of sickle cell disease. And people with sickle cell disease, they experience recurrent episodes of sickling, of acute sickling, leading to different manifestations depending on the organ that is being mainly involved by this sickling. Sickling usually occurs secondary to hypoxia. So any condition that lead to hypoxemia or such as infection or excessive exercise or performing or being in a situation that would lead to hypoxia, such as anesthesia, operation, can increase the risk of having acute sickling, and then patients would go into acute sickling crisis that leads to different disease manifestation, as we said. The disease is inherited in an autosomal recessive pattern. The problem is a single nucleic acid change in the beta globin leading to the disease. As you know, the manifestation can be acute painful episodes or crisis, which is caused by infarction of the bone, and this is called vaso-occlusive crisis. Also, it is the most common form of complication or of a crisis that would happen in sickle cell. Then you have other complications such as infection, anemias, or stroke, or organopathy or organ damage, such as damage to the kidneys, to the retina, to the heart, due to disease or the sickling of red blood cell in these organs. So sickle cell disease is another example of a hemoglobinopathy leading to abnormal cell shape or abnormal cell formation secondary to hypoxia because of this single amino acid substitution in the globin chain. And I think these are the two most common examples that you would see in your clinical practice when it comes to hemoglobinopathies. I mean, thalassemias and sickle cell disease, and they are also the most clinically significant hemoglobinopathies. Case number 6, we said that this is a lady with exertional fatigue and shortness of breath, and a group of symptoms that we agreed on to be likely secondary to anemia. We said these things can be caused, or these symptoms can be caused by anemia or respiratory conditions or cardiac conditions. And we said that she has the risk factors in the history here. She had 3 pregnancies in 5 years, and she has excessive menstrual blood loss. And we said that she doesn't have infection or a bleeding symptom, indicating that she is not having a problem in her immune system or a problem in her coagulation. Her platelet count is expected to be normal. So the findings are pallor, hair loss, koilonychia, angular stomatitis, and abnormal red blood cells. The red blood cells are microcytic, as you can see, hypochromic, a feature that is shared also in patients with thalassemia. However, there is not significant variability in the size or shape as you would see in other conditions of anemias. So it's mainly microcytic hypochromic cells. The nail changes and the angular stomatitis, as you can see, then the pallor. So we agreed that this lady, she has iron deficiency anemia that's secondary to excessive or excess menstrual blood loss, one of the causes of iron deficiency. And and iron deficiency anemia. So causes of iron deficiency anemia can be grouped into four main categories. The first one is excess blood loss, an unusual excess chronic ongoing blood loss, such as the one that you would see in menorrhagia, excessive menstrual blood loss, the one you would see, for example, in patients with excess or with a bleeding tendency, such as von Willebrand disease, if they bleed too much from their nose or gums on a long-term basis, or other forms of blood loss from for example, from the colon, the GI tract, like for example hemorrhoid or diverticulosis or malignancies of the GI tract, like colon cancer or lower GI tract cancer in general, ulcers in the stomach, ulcers, all of these things that can cause chronic long-term bleeding, leading to iron deficiency. Then another group is increased requirement, when there is an increasing requirement for iron. In this example, this lady, she had this because she had 3 pregnancies within a short period of time, so that the growing fetus would also take from the stores from his mother. So you need to make sure that the lady is iron depleted before she gets pregnant. So having multiple pregnancies within a short period of time is always a risk factor to develop iron deficiency. Then we have the dietary causes, as you would expect, because iron is present mainly in two forms, in heme and non-heme sources, and the absorption of non-heme iron is largely affected by chelators in the diet. So you wouldn't expect absorption to be as good as it is if you compare it with heme iron. The heme iron is iron from the animal source, like from the red meat, from the white meat. So this iron is absorbed more easily than non-heme iron. Then the fourth group of causes is under the malabsorption. So anything that can interfere with iron absorption, which is mainly in the duodenum. So the first and the second part of the duodenum are the site of iron absorption, and as you know, it's better absorbed in acidic media. So anything that would interfere with the stomach acidity would also affect absorption of iron. And conditions also such as H. pylori, gastritis, excess use of antacids, celiac disease, and the duodenal villus atrophy associated with the celiac disease also lead to iron deficiency anemia. Also the removal of stomach and duodenum, such as seen in bariatric surgeries, for example, also increases the risk to develop iron deficiency. So these are the main groups, and to show how it can be different from one patient to another, here is another example. Case number 7 is another example for iron deficiency anemia, also that is caused by another cause from another because the context here is different. So this is a 62-year-old male, retired male patient. He has new symptoms of fatigue and shortness of breath again. It started around 2 months ago. He also noticed a change in his bowel habits recently and thinks he's losing weight. So probably this is the source of, or the cause of why he's losing iron, because his bowels are the problem in his bowels. So and they also tell us he's not vegetarian and his diet sounds balanced, so it's unlikely to be of dietary cause. This iron deficiency is likely to be secondary to a problem in his bowels. So what is to do next. In these cases, we should perform an endoscopy, a camera test, to look inside his colon, because it can be a source of the problem. It can be the cause of the problem. It's likely to be bleeding, and this bleeding can be secondary to malignancies, GI, gastrointestinal malignancies. That's why we always say that you should put iron deficiency uh, down to something. You should always try to identify the cause for iron deficiency. It's not the final diagnosis. It's an indication that there is a problem with the iron balance in the system. So it's either blood loss or increased requirement or dietary or malabsorption causes, and your job as a physician is try to identify the cause behind this, because it can be an underlying uncovered bleeding disorder, for example. It can be an underlying undiagnosed cancer, and something that you need to diagnose and act based on that as soon as possible. Case number 8, in this case we presented another form or another case of anemia that is due to a different reason. This lady, she has the risk factor here within the past medical history. She had gastric bypass, a bariatric surgery that was done 10 years ago. And we have another clue, that she's not attending the clinic visits, and she's not taking the prescribed medications. So from this we understand that patients following gastrectomy or gastric bypass for bariatric or for obesity issues, they should receive vitamins on a regular basis. As we said, they are at increased risk to develop iron deficiency. Also they are at increased risk to develop B12 deficiency. The deficiency that this lady has, why we say so? Because she, in addition to anemia, she has this spectrum of neurological manifestation: mental sluggishness, inability to walk, and she's depressed, becoming more forgetful. So she clearly has an element of a neurological condition in addition to her anemia symptoms. And the blood film is showing these characteristic hypersegmented neutrophils, and also it's showing what we call megaloblastic changes in the bone marrow. So the bone marrow, if you study a bone marrow in a patient with severe B12 deficiency, you would see it what's called megaloblastic changes, meaning asynchrony between the nuclear and the cytoplasm maturation. So the cytoplasm is at a different stage of maturation compared to the nucleus. So they are not going hand by hand as you would expect normally. Hypersegmented neutrophil is another term seen in stressed erythropoiesis in general. It's not pathognomic for B12 deficiency, though it is characteristic for the disease. A well-described cause for this, and it's defined as having more than 5 segments in the neutrophil nucleus. Usually there are 3 to 5 segments in the neutrophil nucleus. So this lady, she had all of this in addition to these neurological symptoms, and this is why we think she has vitamin B12 vitamin B12 deficiency, because vitamin B12 is important for the health of a neuron. So a patient with B12 deficiency would have a spectrum of conditions. It usually starts with paresthesia that is symmetrical and bilateral, that can involve both and lower limbs, and then it progresses further to lose the function of motor the vibratory sensation of the lower limbs, and the proprioception sensation also of the lower limb. So it can happen like this, then the gait starts to change, and if the condition is not treated, it progresses further to more serious complications. So always suspect B12 deficiency when there is first of all, when there are risk factors for the condition, because it's important to have the risk factors, and one of the risk factors is having this bariatric surgery, being non-compliant to medications afterwards, also being vegetarian, because B12 is present in dairy, in meat and animal source and dairy products exclusively. So being vegetarian or vegan is without having the proper supplement is another risk factor. Patients with pernicious anemia, which is an autoimmune disease attacking parietal cells of the stomach, also they have an increased risk for vitamin B12 deficiency. Also elderly population, elderly people, they have an increased risk for this. So always suspect B12 deficiency when there are risk factors for the disease, when there is anemia, when the patient is pale, and when there are neurological manifestations. When you see a patient with neurological symptoms and B12 and anemia, always think of vitamin B12 deficiency. Laboratory-wise, these patients, they are anemic, they have a low hemoglobin, they have macrocytes in comparison to microcytes seen in iron deficiency. And also they have in addition to macrocytosis, they may have hemolysis. So it can lead to ineffective erythropoiesis and hematopoiesis, leading to intramedullary destruction. So they can have also hemolytic, a picture of hemolysis when it is severe B12 deficiency. So what you would do next in these patients, you need to treat them as soon as you suspect the condition. So you need to check their B12 and start treatment immediately, because the neurological damage can be irreversible. So the sooner you give them treatment, the better the outcome. Okay, see, these are the groups for these are the causes for a group of causes for iron deficiency. Okay, the last case that we presented in the first lecture is a 64-year-old lady who presents with the acute onset of symptoms that started 1 week ago, and we said when you find all these groups of symptoms, the symptoms of anemia, the symptoms of infection and bleeding, so the triad of anemia symptoms, bleeding symptoms, infective symptoms should make you think of bone marrow issues or bone marrow problems. So it's not just a case of anemia or a case of bleeding tendency as we saw in the previous examples. So there is pallor and there is documented fever. The documented fever is a term that we use to say or to indicate that it is not just a feeling by the patient that they are having or running a fever, but it's also documented, like it's been measured and it's been confirmed that they are having temperature. Then the second, skin bleeding also. So this is a confirmation that they have the triad of these symptoms: pallor, infection, and bleeding. As I told you, when you find these symptoms, when you see these symptoms all together, you should think, is the bone marrow is failing to produce the cells, the proper cells, the end products of hematopoiesis? Is this the case? Because it sounds like this. And what can cause bone marrow failure is primarily two things. The first one is that the bone marrow is not producing the cells as it should. There is reduced hematopoiesis all over. The second scenario is that there are abnormal cells infiltrating the bone marrow, and these abnormal cells are taking over the bone marrow capacity to produce healthy cells, hence ending up with a reduced hematopoiesis overall, because it's being overtaken by these abnormal cells. So these are the two main scenarios when you talk about bone marrow failure. Another possibility of having low count peripherally, that would be in the context of a normal bone marrow, is peripheral destruction, but this is not considered a bone marrow failure, because the bone marrow is producing in this case, but it's a normal hematopoiesis, but the cells are being destructed peripherally by an immune response, or by sometimes by portal hypertension, by hypersplenism, and this is not considered a bone marrow failure in itself. So what do you think this patient may have? If you study the bone marrow or the blood film, it can give you an idea. So this patient blood film and bone marrow is showing infiltration or abnormal infiltration of these cells, which are not normally present in the blood film, and not normally present in excess in bone marrow. So you can see them in bone marrow, but up to a certain percent, not to exceed 5%, and in the peripheral blood you shouldn't see any of them. So these are characteristic cells for the cause or for the condition. These are immature malignant cells that are clonally proliferating. So this is a clonal disorder. Another example of a clonal disorder of the bone marrow, but these are blast cells or immature cells, characterized by high nuclear cytoplasmic ratio, by being large in size, also by having an uncondensed chromatin, abnormal nuclei morphology, as you can see. So these are blasts. So the bone marrow is infiltrated by blasts. So this is acute leukemia. So this case demonstrates how patients with acute leukemia they present. What else you need to see here? This is a thrombocytopenic rash, a rash that you would see in patients with the thrombocytopenia. It's pinpoint reddish spots, usually present on the extremities. The anterior aspects of the legs usually is the site, and trunk is a less common site for this. And this is a bruise also. This is a large bruise that you would see also in patients who have a problem in their platelets, either qualitative or quantitative. And I think by this we conclude the second part of our lecture series, and I hope it's been clear to you. I'm happy to receive any questions on my email, and I'm happy to see you at my office anytime to discuss anything that you need to do or to discuss about these cases. Thank you so much.